Okay. All right. Do my best.
Good. So, hello, everybody. Thank you for coming out tonight. It's a Wednesday. I'm in Maine. Lucky me. I love this place. There's maple syrup and lobster. How can you beat that, right? I try to do it every time I'm here. But, but another great thing about Maine is all the great practitioners and providers that have come out tonight. So we're at Integrative Maine, and Dr. Sean McCloy's nice enough to host the event at his beautiful location. So we have plenty of room for everybody. And we're having a good time networking and learning a bit about each other and what we do and how we practice it. I just wanted to introduce the speaker. We're going to do a talk on hormone health, and Allison Gray, nurse practitioner from Yarmouth.
Yeah.
Or practicing in
Yarmouth. Yeah.
Practicing in Yarmouth. And she started as a labor and delivery nurse originally before she got into becoming a nurse practitioner, and she graduated from the University of Southern Maine in 2016. And now she's a functional medicine nurse practitioner. I met her right around that time. He became a functional nurse practitioner. And I learned a lot about her. And we worked really well together. And once she owned her new practice, I said, "Wow, you'd be a great speaker, and you taught me so much. I'd love to share that with the group." And Allison was nice enough to agree. So we found this as a perfect topic for her to discuss with our group. But introducing Allison Gray.
Hello. Okay, I'm gonna not look at this. It's gonna wear me out at the camera. But hi, everyone in there. I'm gonna try not to look. Thank you. So I'm really, really excited. I love talking about hormone therapy. I am really grateful to be able to kind of, share this with people, because there's been so much that has come up over the past few years with hormone therapy for men and women. Radical changes in what we've been told, what we've been taught, and it's confusing for practitioners. It's confusing for patients. We're all kind of finding our way in it. I was lucky enough to be doing this from the beginning of my career. So I've been doing this for about 8.5 years, and I have seen so many changes, even just with the availability and access, but it's so different everywhere. So tonight, what I want to focus on is just a couple basic things of just where are we now? What is the newest kind of conventional guidance? I definitely will talk a lot more about how I practice or what I do as well. It's not exactly in the, in the lines as the newer guidelines have come out. But I also want to just acknowledge before I jump in that hormone stuff doesn't happen in a vacuum. I'm going to focus a lot on hormone stuff, but I know everyone in this room knows that that wouldn't be the only thing we do. We look at all kinds of areas of health because they're absolutely intertwined. I'm going to focus mostly on hormone health, but I'm happy to talk about other stuff I do or work with people. I have some slides and information on other supplements, other health areas. There are definitely some things that I see a lot in my practice that present as hormone symptoms, but can be other things. So I'll talk about those because it's something that I find is not looked at all in conventional medicine. But I also want this to be valuable. So I'm going to talk about the stuff I have. I'm going to go through the slides that I have, but I want to leave space for questions. I have some case studies, so we'll see what people want to do. But I definitely want to hear your questions and know what people are wanting to know about, because this is such a broad field. I am talking about men and women. I'm probably going to talk more about women's hormones for the most part. I do provide care for men and women in my practice, so I can answer any questions. There's all kinds of other experts here too. But I will mostly probably focus more so on women's health, just because that's something that is just more complex right now, especially. So I'm going to jump in. And I think it's this side. Yeah, there you go. Oh, no. Oh, perfect. I don't even know. So just kind of overview of what we're talking about. But again, there's flexibility. So I want to talk about whatever you guys want to hear, and we'll leave space for that. But just kind of like who can benefit, where can we get hormone replacement therapy? What is new for timing, starting, stopping, all that stuff. So we'll kind of go over it. I'm going to share what the recommendations are, and I'm also going to share what I do. So there might be a little bit of gray area, which is kind of my happy place. So perfect. Okay, so big take-home messages. I really wanted to highlight these. vaginal estrogen for most, okay, I have to put that in, but vaginal estrogen for most women is safe, it's effective, and it's helpful. Even women who have had cancer, even women who have hormone positive cancer, we know now that the vaginal estrogen is so rarely going to change serum levels and systemic levels that the risk level there is so low that it should be offered to women who are symptomatic at the very least. If you're not sure and you have someone who's got, you know, any kind of a cancer history or something like that, like you can always even just ask to consult with their oncologist or something like that. Or maybe it's, you know, just someone you refer out to someone who has more comfort with it. But I will tell you that, you know, it's been one of the big kind of surprises that came out of reevaluating the Women's Health Initiative, which I'll kind of talk about in a minute, is that, you know, estrogen is not the big scary monster under the bed we thought it was. And if estrogen really caused cancer as much as we thought it was, then women would not be developing cancer at higher rates in menopause when estrogen drops off a cliff, right? We would see that more when people are pregnant, when their estrogen is sky high. We'd see it when they're, you know, in cycling phases. So there's so much more to this, but I just want everyone to know, if I can share one thing for practitioners, especially practitioners who are prescribing, it's very rare that a vaginal estrogen would not be a good fit for someone, but you just need to you know, do the due diligence, talk with pharmacists, talk with other oncologists who know what they're doing, but it is life-changing for women who are experiencing, they call it GSM for a while, but like genitourinary symptoms of menopause, but vaginal dryness, vaginal irritation, which, by the way, it leads to higher rates of UTIs. And we know UTIs equal mortality for certain populations. So literally this can be life-changing and life-saving. But just to prevent UTIs and prevent discomfort, but also to help people have intimacy and sexual pleasure. Those are things we don't obviously talk about a lot in practice. Well, people here probably do, but I don't think it's valued the way it needs to be for people who are really struggling. And so anyway, that's a big take home. Hormone therapy is now emerging as not only safe, but preventative, healthy, helpful for the right people. So we really, everyone here knows, we can't say one thing works great for everyone, right? Everyone who's into functional medicine, obviously we know that it needs to be individualized, which is why conventional medicine probably has had a harder time with hormone therapy, because you really can't say there's just one way to do it. However, most importantly, people who do benefit, if we start before chronic disease develops, there are preventative outcomes with hormone therapy for so many chronic diseases that, you know, I really see this is going to change over time, but we all know medicine takes such a long time to change practice. But just for people understanding, it's also important to be screening and understanding who's a good candidate, because with hormone therapy and hormone balancing, whatever version we do, we can prevent chronic disease, and we can prevent some, you know, worse health outcomes. Women who've had surgical menopause at an early age, if they are not put on hormone therapy, they die sooner. They have worse health compared to women who are on hormone therapy. Women who are on hormone therapy after menopause live longer and are healthier. Like, it is just one of those things that we are not integrating yet into practice, you know, in education and practice in the conventional world, but we know that from the data. We know from the information that's come out after we've gone back and looked at what was reported and what was real. So I'll get more into that. Another thing, so if you are, especially if you're working with men, but I'd say men and women, something a lot of people don't know about, if you're ordering labs and interpreting labs, you really need to look at more than just total testosterone. Total testosterone is helpful, it's a guidepost, but not all of it is available. So sex hormone binding globulin, we'll talk more about it, it's like a sponge. So if you have a really big sponge and a lot of hormones are stuck to it, you don't have as much out there available for use. I've seen it so many times where either men have come in and said, oh, my testosterone was fine, and it's in the toilet and they're symptomatic and miserable, or women are like, oh, they told me I have PCOS, and I checked their free testosterone, it's not even close to elevated. So just to take home important things, checking a free testosterone with your total is very important. And the kinds of hormones you use matters. They're not all the same, very, very different in a lot of ways, a lot of options. I'm probably going to talk more about like bioidentical hormones tonight. I can speak a little to conventional, there are conventional bioidentical hormones available in commercial pharmacies. The patch is considered bioidentical, it's estradiol. Creams, there's a vaginal ring. So we have options. In my experience, I find that there isn't as good coverage with those options. I find being able to individualize and compound therapy for someone based on their symptoms, their numbers, their needs is far more effective. But for a lot of women, that's all they can get. And so I would rather people have access. So I'm glad they can, but there's a lot of different options. So just saying hormone therapy is really just such a broad term. Okay, thank you. Oh, that's good. These are probably the newest studies that you could go to look at some of the newest data we have on hormone therapy for men and for women. I won't go too far into it just because I'd rather kind of talk about other stuff, but I do reference some of these things. NAMS, I think they just changed their name. So it's North American Menopause Society. I think they're now just Menopause Society. They really kind of were the ones that blew the lid off the Women's Health Initiative. The Women's Health Initiative, you guys probably all know, but it was done in the early 2000s. It was a study with, actually, would you mind going to the next slide? Because I think I might have had some, yeah, okay. So the Women's Health Initiative was really geared, the FDA required the study to be done because a lot of women were on hormones in the 90s and loving it, loving life. There was a lot of treatment for osteoporosis, just hot flashes, night sweats, menopause in general. So the FDA said, okay, well, let's make sure that this isn't causing like heart attacks or cancer or whatever. So they did this huge longitudinal study. And there was a lot that came out about how unsafe hormones were after that point. But as time went on, hormones were kind of demonized, right? Like, I mean, even still to this day, a lot of people still think that it's just very unsafe. What happened was over time, people started to say, you know what, is this data accurate? Maybe we need to go back and recheck. And I'll say as someone practicing in that time frame of like when, the information hadn't come out about how safe they were, it was kind of like practicing without a safety net, but I kept seeing people on the other side get so much healthier and happier. And then the downstream of having hormones balanced, of eating better and exercising more and feeling better about your life. Like you really have so many other things that come from it. So I would hear all these things and just think, God, that's not what I'm seeing. It was a little nerve-wracking, but mostly it wasn't because people really were doing well. But now, even better, we have data to support the practice. So Women's Health Initiative, basic take-homes, some of the reasons why these things came out, some of the reasons why some of the endpoints were the way they were. One is, in order to do double-blind randomized control, they started with asymptomatic women, first of all. So do these women even need hormone therapy? If you don't have symptoms, I mean, I would argue there's probably some benefits, but we're not measuring how this affects people who are symptomatic. So I would say that it's rare people test labs for women's health for hormone therapy. I mean, probably in conventional medicine. In functional medicine, a lot of us do, obviously. But I would say it's pretty clear to me when I look at labs and people are symptomatic, their labs are not, they're, oh, I think I'm plugged in. What's happening? Let me try the other side. Oh, we were crushing it. What happened? There we go. All right, just didn't like that side. So that was one piece. Women over the age of 60 were also the demographic. Again, a lot of women are already through menopause at that point. They use synthetic oral hormones, Premarin and Provera, made from horse urine, not the same as a bioidentical. The big thing too that we're looking into now, and I think a lot of data is going to come out, is the synthetic progestins. We think now are kind of what some of the troublemakers were. They really were probably the troublemakers. Synthetic progestins were used to offset endometrial overgrowth. So these are being studied, they're being looked at and accounted for. But one of the things that was considered, in the study, if you were a woman with a uterus, you were given progesterone or progestin with your estrogen to keep that uterine lining in check. Because if we don't give that and you have estrogen on board, you're going to grow that lining of the uterus with no kind of checks and balances. I also would say, to me, progesterone is a really important hormone in general. So even if I work with a woman who's had a hysterectomy, I'm still bringing that on board if that's beneficial. But this is just kind of the baseline of this study. They had clinical trials, they had observational studies, and they had a lot of endpoints but the clinical trials were osteoporosis, heart disease, breast cancer. So without getting too much more into the weeds, basically they have reevaluated the whole study. They've looked at some of the clinical trials, they've analyzed the data, and as it turns out, when they were reporting risk, it was risk in groups of women or in percentages that weren't really reflective of what was actually risky for, the greater population. Now that they've gone back and started looking You know, we need to do a lot more studies. That's all it comes down to. There's no evidence-based hormone therapy. You know, no one's gone out to even say, hey, like we highly recommend this, even though, you know, North American Menopause Society kind of, you know, tipped the apple cart over here. But all that to say, I think it's coming. And I think there's going to be a lot of helpful data. The data we do have, like we have some very clear data. We know from this study that women who were on hormone therapy, if they developed breast cancer, had better outcomes. They also postulated that perhaps giving estrogen to a woman who might have been going to develop breast cancer, that it didn't give her breast cancer, but it actually probably brought it up to be found like sooner. And maybe that's, they've kind of wondered, is that maybe why the outcomes were that way? We know it decreases UTIs. That equals UTIs equal mortality, especially later in life. We know that there's lower rates of colon cancer. There are much better outcomes with bone density, osteoporosis. There's no better treatment for osteoporosis than estrogen. So there's a lot of benefits. There's a lot of things. We have barely even scratched the surface of testosterone for women. We barely scratched it for men, really. So there's a lot of benefits they're starting to look at there. The men's study that I was referencing there, I'm not sure if anyone's like interested, but the Traverse study is something they just did. Okay, all right. I know, like I don't want to get too nerdy, but the Traverse study, I would, if you are interested, I would recommend going to read it, what their findings were, because what we have heard about testosterone therapy for men for a long time. Well, what have you guys heard? Like, what do you hear are some of the possible risks for hormone therapy for men, even if you know they're not true? Cardiovascular, right? So the Traverse study, the endpoints specifically were cardiovascular health. What they found was the risk benefit was really that the cardiovascular outcomes were not risky enough to say you shouldn't use it. They were basically equal in risk of using testosterone, not using testosterone. There were some outcomes that they were surprised about that hadn't been found in other studies, so they're going back to test them. Kidney issues being one, and I forget what the other one was. But all that to say, you know, we've ruled out prostate cancer, right? In fact, they're doing studies right now to test high-dose testosterone as treatment for prostate cancer, interestingly. So we've ruled out prostate cancer being an issue. We've ruled out, you know, some major cardiovascular things. I personally, if someone has like a sleep apnea, first of all, sleep apnea is something that could be worsened by testosterone therapy, but there's a lot of people where the risk benefit of being on testosterone therapy and getting healthier and having a better weight and eating better and exercising sometimes will help that as well. So I think there's some kind of balance with hormone therapy with some of these things. But overall, right now, I think we're going to see a lot more studies coming out. Currently, cardiovascular health for men with testosterone therapy is, you know, this study was only like a year ago, so you probably haven't heard about it, but it's not considered enough of a risk to not offer it if someone is a good candidate. So thank you. I won't read all this, but those are, I think I covered a lot of them. One thing I want to say is a big one with estrogen therapy. So what was one of the risks we heard about for estrogen therapy, other than cancer?
Cardiovascular as well.
Cardiovascular, especially like a stroke risk. So they were giving horse urine tablets, you know, to women. And, you know, that obviously goes to the gut, goes to the liver. When we use transdermal estrogen, the risk is nil. So you don't have the same concerns with a transdermal. However, I don't even know if anyone's prescribing oral tablet anymore, maybe, but that's the only one that would be a risk factor for a clot for a woman. Just on that note too, for men, I think it would be risky probably for a testosterone tablet. I don't think a lot of people do that, but they're out there, and it is also a risk just because of the, you know, gut and liver involvement. Okay, yeah, thank you. Okay, true or false? Ovaries produce more testosterone than estrogen. I mean, you have to guess true, right? But if you press it, I figured out how to make it, yes. Yeah, it's true. So now a lot of that testosterone goes and converts to estrogen, but, you know, we barely even talk about testosterone for women. And I have to tell you, in my practice, most of the women I work with who are perimenopausal or not close to perimenopause yet, you know, cycling phase, most of them benefit and don't need estrogen. Most of them just benefit from testosterone and progesterone. And I'll go way more into that, but it's amazing. And it's very small doses. It's obviously not the same as men, but people, obviously that's one we wouldn't expect, but just to kind of make the point that women need and have testosterone as well. Thank you. All right, so who's a good candidate? So nowadays, I would say that there are conventional medicine standards that if women are symptomatic, now what they're trying to push, if they're symptomatic and perimenopausal or menopausal, that they will be, you know, they'll have access to estrogen, they'll have access to hormones. So they're not looking at lab levels. I personally do look at lab levels of everyone who walks through the door who's coming to see me for hormone therapy, and most functional medicine too. So I do like to see those numbers. It's not required, but I find it incredibly helpful because one, you know where they're starting from, you know where those ranges are. There's no determined ranges, which is probably why, I mean, we know the reference range, but there's no determined like, you know, healthy range or optimal range. I use the ones I use for, you know, many reasons, and I'll go over them if you want. But I just want to say there's nothing that's been like approved to use. It's just that I don't think it's that hard to see if someone starts out deficient or really low and they're in the upper optimal and feeling good, that like, oh, that's their sweet spot, you know? So I like it because it gives me context. I had someone just today who came in. She was coming in for her intake visit for hormone therapy. She had seen her, this was surprising to me. She had seen her GYN for a visit, and she told her that she was having vaginal dryness and some symptoms. And she's like, oh, I'll just prescribe you estrogen. I'm like, well, that's amazing. First of all, they haven't been so, you know, easily swayed there, but she was really pushing it. And she was like, this woman is still having her period. And she was like, I don't, she just felt intuitively she didn't need that. And we tested her levels, and she was right. Her estrogen was fine. It was actually really good. And had she been given the estrogen I mean, I do just want to just say that I'm happy that conventional medicine is doing that more, but it might have actually made her cycles weirder because it would have been growing the lining of the uterus. You know, what she really needed, her progesterone was in the toilet. It was like lower than menopausal range, and her testosterone was low. So just as an example, like I'm very happy they're offering it now. They don't test labs, but the bar for who's a good candidate now for hormone therapy is really different. And the guidance is out there. But I think you're going to see it changing a lot. It's really moving more towards, you know, who's symptomatic, who could benefit from this, and what are they good candidates for safety-wise. Just some benefits here that we know. I've mentioned some of them, but for men, this is one, I have a case study if I get to it, but this is what happened in this particular situation. And I didn't know this until I was like preparing for this, that unexplained anemia is actually approved treatment, testosterone treatment, which I've seen happen, but I didn't realize they even had that kind of listed. But the other ones I think you probably kind of are aware of, but the mood improvement, there's a lot of data for men, especially with anxiety, depression, that when you have low testosterone levels and you optimize them, there is improvement. For women, I think I've talked about most of these, but we'll go more into it.
Anemia as well? The protein?
Well, I would say
Good
I don't
question.
see it. Yeah, what's that?
Repeat the question.
Oh, yeah. So the question is, do women get anemia from low testosterone? Well, I want to flip it around and say, I don't know that low testosterone is the cause of low anemia for men. So I think I'd have to start there. But when you give testosterone, you increase red blood cell production. So then red blood cell production, you know, is.
And of course, I'm thinking postmenopause.
Yeah.
I don't make it confusing.
Well, you know, what I see a lot more that happens, and this is why I send people over here all the time. A lot of women have really low ferritin and low, and they have anemia, but no one's looking at it because they're menopausal. So they're like, we don't need iron anymore. And they've just been anemic their whole life. No one looks at it. But I have a feeling it's probably not as much from the testosterone. It's probably more for a menopausal woman. If you correct it, unless they're losing it somewhere, they should be fine. But it's usually just from a life of having periods and kids and all that. But I don't see it as like, I don't see it move down the red blood cells as much as other things, I guess I'd say. Yeah.
Any data on dementia prevention for men with testosterone?
Not yet. I think for men and women, that is a huge one. They're going to be there. People are talking about it and seeing it and observationally, and there's some data, but not enough, I think, for them to say officially. However, I don't think it's that far off at all.
Right.
Yeah. Yeah, that's a big one just in practice that I see for men and women. Brain fog, memory, those things shift very quickly.
So I might be like pushing part of the edge here. I don't know if you've seen or if you looked at, and I'm curious from your opinion, using progesterone post-traumatic brain injuries.
Yes. So someone's asking about progesterone post-traumatic brain injury. So I actually read about that one time. JJ Virgin, do you guys know who she is? She's in the functional medicine world. Her son was in a car accident. She was like sneaking things into the hospital to take care of him. She used high dose progesterone for him. And so I don't know much about it. I know it's used enough. Actually, I have someone who they're in like mixed martial arts and has had a lot of head trauma. And we trialed it out. We did levels. We trialed out some stuff for brain function and didn't seem to hurt. We weren't sure if it was that or other things. But yeah, have you heard a lot about it?
So I don't know a ton about it, to be honest with you, but I work with a lot of patients with trauma histories.
Yeah.
So when you look at trauma, like a brain of trauma history and a traumatic brain injury, you're still looking at those neural types that are altered.
Yeah.
Right?
Yeah.
And a lot of them are women.
Yeah.
And a lot of them have very low.
Interesting. So women she's seeing in her clinic, I'm just saying for you guys.
I'm sorry. So we'll pair progesterone therapies with like EMDR therapies.
Yeah.
And their outcomes can be much better than just EMDR alone.
Well, and so pairing progesterone with EMDR treatments in the clinic that this person is talking about seems to have better outcomes for the people who are utilizing that therapy, which is amazing for them to access that with you. And also that, you know, we know that when women are menopausal or postpartum, right? I mean, anyone who's been there, like you can't think straight, like you can't even remember anything. It's insane, right? I don't know the association yet, but I know we're looking into it because we know that the changes that happen, like dementia is, I can't fully say it, but a lot of people, even in the conventional world, know that better hormone therapy is really showing that dementia is not happening the same way. So I think we're going to see a lot more. But by the way, when we say traumatic brain injury and all we do is study men, right? Like we don't even know the effect of hormone on brain health. Like we haven't even begun to start to separate out research on men and women.
And you can use pregnenolone too.
Yes, thank you. Pregnenolone was mentioned, and yes, absolutely. And actually, well, maybe we can talk more as we're doing questions too, because the downstream impact of that is obviously going to convert, and then you get something upstream because if they're not making progesterone, then you might be giving them the thing that they're missing. So yeah. These are the recommendations I think we've heard for a while, but now they're like a little more expanded. So the most beneficial time to start hormone therapy, I would say there's a lot of women who haven't even gone into perimenopause that can benefit from hormone therapy. But for menopausal women, what we're finding is if you're starting hormones and they're symptomatic, so one thing that is shown is if women have hot flashes, that there is higher cardiovascular risk. So if you are just catching her, and when we give them hormones, they have lower cardiovascular risk. So if we're catching women when their symptoms are starting, then we're able to prevent some of these things. It is not the same impact if you start this after they have developed cardiovascular disease, chronic health stuff. So that's why it's important for us to be kind of aware of who's symptomatic and the benefits and what they can be using. Age 50 to 60 or 10 years within menopause, again, we see the most benefit because we're starting early, we're getting ahead of it. And I would argue when people are hormonally balanced, they usually are feeling more, drive to go work out and eat healthier and do more things that bring them joy. So I think there's more than just the age.
Quick, Sally down in Rhode Island said they can't hear the questions when people ask it, so she said it's hard. And
thank you, Sally. We'll narrow them to question time, you mean, or do you just want me to?
Yeah.
Okay. Thank you, Sally. Yes. And then, so for women over the age of 60, it used to be like, oh, you can't, you have, like, I've had a lot of women that would come to see me that they got stopped. They were on hormone therapy and their providers took them off. Like, oh my God, you're the mountaintop. And then they're like, get back down in the valley of dry riverbed. So now we know that rule, even in conventional medicine, it's not the same anymore. So the conventional recommendations are that if a woman's 10 years outside of menopause, or if she's over 60, there's still a lot of benefit. It's just more of a conversation with her, and she gets to make the decision of here's the risk benefit. So this is just a quick visual of, why perimenopause is so difficult to kind of get a handle on in medicine, because we have these changes that happen. But I just want to point something out. And this is what I was saying before, where I find in my practice, most women who are still cycling, they don't really need estrogen until like pretty much the very end. And you'll see this chart, progesterone is kind of dropping off a little sooner here, and testosterone goes down a little sooner as well. Melatonin, I actually don't know a lot about that part. It doesn't surprise me. But I happen to grab this picture, but I'm interested in that. But anyway, progesterone, testosterone kind of drop off first, and then estrogen is like this. So bleeding, no bleeding, spotting, no bleeding, 9 months. Oh, just kidding, had a period, not menopausal yet. Because you have to be 12 months with no cycle, and an FSH of over 30 is the definition. So that's why it's a crazy little chart. Common symptoms of menopause. So some of these you guys are in perimenopause. You guys are probably aware of a lot of them, but a couple I wanted to point out. One is, I see this a lot and I hear this a lot, heart palpitations, which, you know, the heart has a lot of receptors for men and women for estrogen and testosterone. So when you start to lose the production and those receptors aren't being stimulated anymore, then you become symptomatic. So I don't think I'm always grateful when a woman comes in and says she has heart palpitations, but she's gone to cardiology and they've ruled everything out. I'm like, great. Because also we do a horrible job with cardiovascular health for women and heart health. And so making sure someone has had that to make sure they're clear, that makes me feel better. And I would recommend someone consulting with someone if they haven't, because I think that's important. I still think it's a good idea to provide hormone therapy if they need it, but I think that ruling out anything else major is also a good idea. Vertigo is another one that people aren't super aware of always. Lichen sclerosis, if you guys have heard of that, it's a diagnosis of basically, it's like an eczema of the vaginal labial tissue. I say eczema, it's like, you know, dry, irritated skin. The common treatment for it is, anyone want to guess? Yeah, topical steroids, which I don't know, I don't find it to be super effective. I think it keeps it from being absolutely miserable, but what really helps is estrogen, testosterone. There's a lot of people that use DHEA too. I don't use that as much vaginally, but I think it's a great tool and I have it on some of the slides. I just don't have as much experience with it. But I mean, literally within like weeks to months, you can see this clear and be done and gone. So it's something that women live with and they deal with, and it's miserable. It affects their, like, just urinating, having any kind of intimacy, and just general, you know, feeling okay in the world. Like, this is a big thing to be able to address. Okay, yeah. Cycling women, similar, but I will say, so hormone irregularities show up as, they still can have all these things, but I will throw out there that I work with a lot of women, and I mean, I guess probably a lot of you guys in this room do, where they have this diagnosis of like endometriosis or PCOS. I hear estrogen dominance a lot, and I'll talk about that if you want. Fibroids, infertility. So this is something that hormone therapy can be really helpful for all these things, among many other layers that we work on, you know, in functional medicine. But what I find with younger women, I have this conversation is, if we address the upstream stuff, you probably don't need this therapy anymore. If they're close to perimenopause, they might ride it out. But I work with a lot of younger women in like their 20s and 30s. So I have that conversation, like this might not be something you need forever, but let's get you feeling okay. So you also have the gas tank to do the lifestyle things. And then, you know, it's a easier process.
Can I ask a quick question? Sure. Because I heard it asked over there and I'm curious. What is GSM?
The question is, what is GSM? It's genital urinary symptoms of menopause. It's like, I should have written it out and I apologize. It was very long. I should have written it out. That is on me. But yes, that's what it is. So basically, vaginal dryness, irritation, decreased sensitivity, urinary urgency and frequency. So a lot of women I work with, and men too, by the way, when you have muscle tissue in the pelvis that is not stimulated by hormones anymore, and those receptors are not getting stimulated, then you have muscle tissue that is more lax. It's more responsive if you have it stimulated with hormones. So if someone is having urinary frequency or nighttime urination, that kind of thing, I see that improve a lot. So I would say that's under that umbrella too. Thank you. Sure. Yeah, I think I talked about that one. But just the other thing, just to really take home, is you don't have to stop HRT. It's not recommended anymore that you have to. It's just it's a risk benefit as time goes on. And things might change if someone isn't a good candidate anymore, but that can be a conversation with a provider ongoing. There's no set time to stop anymore like there used to be. Okay, so for men, there's some really obvious things, low libido, but I can't tell you the amount of guys that I've had come in who have said, my libido is fine, and their testosterone is in the toilet, and they have a lot of other symptoms, and especially younger guys who wouldn't even have been screened. Like, they can't even get screened or lab levels with their provider if they try. So we know for men and women, we live in a really toxic world. We have a lot of hormone modulators. We have a lot of stress. We have worse hormones than ever. In fact, to the point where on my lab levels, I don't know anyone else who looks at labs, the normal range or reference range for men for testosterone used to be a certain number, and then they dropped it a couple of years ago. So it was like, oh, men's hormones are low. Well, instead of addressing why, we're like, we're just going to change the goalpost. Now it looks normal. Insane, right? So it's something that shows up more than just libido. So a lot of guys just can't even put their finger on it. It's like, they just don't have the same drive, right? They just, and I don't like to call it motivation because I feel like that's such a kind of Yeah, but it's like that just excitement or like joie de vivre, like just excitement about life. But it's really obvious with sexual health, like fewer morning erections. I say erectile dissatisfaction. I think it's just an easier way to encompass because someone could still have an erection, but it might not be as sensitive. It might take longer to achieve an orgasm. Body weight composition changes are pretty obvious. Insomnia, that's one I think people are not as aware of. For women, I think it's probably more associated with progesterone, estrogen, but for men, big changes with sleep and testosterone therapy. Fatigue, obviously, and depression, anxiety, huge. There's probably many more we could talk about, but those are some that I thought might be helpful if you're working with people and thinking, maybe this might be something to screen for, and helping people, if you're not someone who does the labs or prescribing, having the people in your wheelhouse who do, so you can send them for that to see. Because I work with a lot of guys in their 30s and 40s, 50s, 60s. I mean, it's difficult for them to get the right screening. We don't have to talk about that too much. That is just, if anyone wants these slides, I'll send it. This is a summary of all the things from the Traversity. Oh, I just want to say about that. They did use a topical gel, a little different. Most of the time I'm working with people, I'm using injectables, but something to keep in mind. But I mean, it's basically the outcomes were there's no bigger risk of cardiovascular health for people using testosterone. There are some categories that they might be more at risk, and you have to suss that out. So you can read into it and kind of figure that out. But for most people, it's a healthy option. So just kind of quick overview of, there's a lot of ways that we can deliver hormones. So there's commercial pharmacies, there's compounding pharmacies. I think I might have titled that wrong. So just take out commercial pharmacies off the top. They don't all make all those. This is just kind of a big list. So you can get hormones in many, many different options. And that is nice because some people don't want to do an injection. Some people don't want to do a cream every day. Were you just comfy? Okay. All right. So there's a lot of options. Some of them are more effective than others. There's definitely some better options, but sometimes it's like, if that's the only option, then it's better than nothing. So just again, I won't spend too much time on these, but just to kind of give some of the background of how you can get things. My feelings on pellets, I am totally cool with whoever wants to do what with their life and their body, totally fine. I find pellets to be really difficult to work with, in that, more so for women especially, because once you put a pellet in, you get a real big jump. You don't always even know what their happy baseline is, but it's not a steady coverage. So you get this jump for 3 months and then, well, jump for a month and a half and then down for a month and a half. And I find there's a lot of breakthrough bleeding or side effect symptoms or acne or weird stuff. And you could put a pellet in one person and their number goes to optimal. You could put a pellet in another person, it's way, way, way high. So there's a lot of clinics out there that aren't super responsible about this stuff. I feel like in Maine that, I think it's a little different energy, but other places too, there's a lot of places that just throw pellets in anyone. They don't retest the labs. People are losing their hair. There's like not good stuff happening. You can probably use them effectively and responsibly. It just means you need to like actually do some work with people, but they could be a good option. I just think my 2 cents is I don't find them to be as maybe consistent as the other options, but for some people, if it's the only option or the best option, cool. Like that's fine. Yeah, thank you. And the last slide, just first line in conventional medicine right now for menopause. Do you know what it is most of the time? What's the first line of therapy that a conventional medicine person might recommend if someone comes in with symptoms for menopause? Yeah, SSRIs, an IUD, maybe both. And the interesting thing with an SSRI is it increases sex hormone binding globulin. So now you already have low hormones, and guess what? They're going to get even lower. And you're like, wow, I don't know why I don't want to have sex and I hate the world, right? Like everything is really low at that point. I want to back that up. If it works for people and it's a good option, awesome. But I just find, obviously in my practice, I have a higher proportion of people unhappy with their care, so they come to see me, but I'm sure there are people where that is a good option. It's just not really addressing the upstream problem. Okay, we can keep going. Sorry, I will mention, for men's hormones, injectable testosterone, you can do troches, you can do topical pellets, but there are men that are good candidates for enclomiphene or clomiphene. I won't get too far into it, but I would take questions about it if you want to talk more about it. There's some determining factors of who might be more responsive than others. Clomiphene is a newer version of enclomiphene is a newer version of clomiphene. It's just a few less ingredients, so it seems to be even more effective because there's not as much kind of like side effects. Thank you. So when you were talking about pregnenolone, I just wanted to show, so one thing is when I have people who come in and who have high cholesterol, one of the things I see downstream after they've been on hormone therapy for a while is that number will drop sometimes for a lot of people, because one of the things that's happening is as these numbers over here are low, and then this number over here might be high, the body's like, hey, how do I help? I mean, the body's pretty well designed. So one of the things it's going to do is maybe hold on to or increase cholesterol. The other thing, I'm sure a lot of you guys are aware, but if cholesterol is high, the question is why. You know, maybe it's diet and lifestyle, but a lot of times it's inflammation, it's trying to heal something. Like I tell people all the time, I don't even like to call LDL bad cholesterol. It's like important, it's got a job. So cholesterol then converts to pregnenolone, DHEA. Now, depending on how someone's levels are, this might shift a little. If you have really low progesterone or really high cortisol versus, you know, high estrogen or low testosterone, these arrows might be going somewhere else to compensate. But just to give you an idea, and when we're talking about DHEA as an option, pregnenolone as an option, these are things you can get over the counter. These, you don't, I mean, there's topical DHEA. I don't know that it's prescription actually. Is it prescription?
Oh, no, just.
Okay, yeah, because I was like, I'm actually not sure, but either way, these can be great options, right? If someone is able to, and especially I would say earlier on in the changes of hormones, if you can catch some of these upstream things, you might not need to do the hormone therapy. Down the road, they might still benefit, because at some point there are people who they just drop off, and as many nutrients and lifestyle and diet as you do, they're just going to still be symptomatic. But there's a lot of people where if we start here, now they have to be able to convert, right? And we could totally get in the weeds of all the reasons why someone might not convert as well. But you could test things, right? Like I do that a lot where like we might try an intervention and we test 3 months later and just see if we move the dial. So you don't have to guess, you know, and how are they feeling more importantly. Okay, on average, men have more estradiol than menopausal women. True or false?
True.
You have to hit the button for my magical
sorry.
true. No, it's okay. I just was really excited for that to slide over. Yeah, it's true. So, and I say this as kind of tongue in cheek, but it's true in that I look at labs a lot. Menopausal women come in with estrogen easily, like if it's even measured, if you can, I have a lot of women where the number is so low, it's below 5, can't see it. Lots of women who are menopausal and symptomatic come in and they're between like 0 and 30, very symptomatic. Most men I work with, they might be 20, 30, maybe 40, maybe 50. So I just say this to say there's a lot of men walking around out there with more estrogen in their bodies than a menopausal woman. And yet we're like, oh, don't give them estrogen. It's like, okay, well, can we at least catch up with men? Is that okay? You know? All right. These are the, I won't get too far into this. I'm happy to go back into this stuff if people want to. I wrote up what I use personally as my optimal ranges. Some of these are reference ranges, but I'll tell you the optimal. These are not like, this is not evidence-based, but these are reference ranges. What I find is there is a sweet spot for most people to land, but I'm also very open that some people fall outside that range that I use, and it's okay if they feel good and there aren't bad side effects and we're not like way up, you know, too high, then I can hang places. But there are target goals that I tell people that people typically feel best in. So when I'm talking about, you know, total testosterone for men, I don't even really use this, to be honest. I mean, it's helpful. I shouldn't say that, but this isn't what I guide my therapy on. What I guide my therapy on is the free testosterone. This is an optimal range. The normal range is like 40. They changed it. So now it's like 40 to like 180. It used to be 40 to 250. So we changed the goalpost because men's hormones are lower than ever. So I don't mind if they hang up there. And as long as their H&H looks good, and as long as their estrogen looks good, and as long as they're not having negative side effects, that's okay. And I test labs pretty frequently comparatively. So it's like, I'm not going to have a situation, and if people don't change their dosing, they're probably going to hang there. So for women, there's ranges for free testosterone. Again, women, I don't use total very often because that sex hormone binding globulin, I don't have that up here because it's not really an optimal range thing, but there's a high and low. And if someone has a high binding globulin, you can just have on your radar that they probably aren't absorbing much or using much of what is showing up on the page. There are medications that are common that increase binding globulin, statins, SSRIs, birth control pills, antihypertensive. So there's a lot of common medications. People are on more than one and their hormones are in the tank. You'd never know it because when we only look at their total, they look great, right? So there's a lot of people who can benefit by looking.
So as like in my practice and like I'm only a. So I can't really like manipulate pharmaceuticals, so I'm always relying on my physician.
Yeah.
But if we're using a bioidentical support, is it counterintuitive to be using it with those pharmaceuticals in play, or is it beneficial?
The question is it worth using bioidenticals with more commercial preparations? Do you mean of hormones specifically? That's a really good question. So the question is, should you use bioidenticals while you're using commercial or synthetic, I guess we'd say?
So I guess to clarify the question, let's say they're on hypertensive medication.
Yes.
Can you still benefit from using a bioidentical?
Yes. Okay. So if they're on, for example, an antihypertensive and they end up needing hormones, yeah, absolutely. Now, again, I want to say this: if someone's blood pressure is totally out of control and they are not like well-controlled blood pressure or whatever, that's a different story. I'd want to kind of make sure that's maybe dialed in. But most people I work with, yes, I will start testosterone or bioidenticals while they're on those medications. And in fact, I see a lot of people coming off medications over time.
Yeah, I typically work with diet to get them off medication first.
Oh, that's even better, truly.
Then we add the hormone.
Yes.
To support their need, but like if I can use it at the same time and get them to get better faster.
Yes.
Great.
Yeah. So what she was saying, she's a nutritionist, and so she uses that tool a lot to help people come off those medications and then maybe get ready for hormone therapy. But to your point, I find that though I know in the grand scheme of life, addressing upstream things is the best option, of course. However, most people have been hormonally deficient for so long and they're so miserable and they are just like over it, that asking them to do like an elimination diet or something like that, or start to do diet changes, it's not even, they can't even put one foot in front of the other a lot of times. So what I do is I tell them, listen, I'm going to address this deficiency, and this is something that probably will be helpful. And the upstream things are really important, but we want to put gas in your tank for you to be able to do that. So they understand, and most people, I mean, I'm working with people on more than just that. There are some people where it's cut and dry. They come in like, health stuff is really dialed in and it is just hormones and they feel great. And like, we don't have to do a lot of their stuff, but most people we are, for sure. Okay, I'll go back to these if anyone wants. Oh, sorry, one other thing. With progesterone, when women are menopausal, it doesn't matter when you draw it. When women are having cycles, progesterone needs to be drawn to be able to see what is progesterone really doing. You need to draw it in the luteal phase, which is day 8. Well, it's a couple days after ovulation, but technically to get the best kind of accurate number, day 18 to 22 is ideal for drawing progesterone. However, you know, if you're day before or after, I don't really get that worked up about it. But the first half of the cycle, progesterone's here and it doesn't come in and do its thing until after ovulation. So if we're drawing it the first half of the cycle, we're only going to see a low number, but it's supposed to be low. So we need to draw it the second half. That's where it shines. So if it's not optimal there and people have PMS, heavy cycles, endometriosis, fibroids, that's when we'll bring that on. The optimal range, so the normal range of progesterone for women in the luteal phase is like 1.4 to 25. I find between 10 and 20 is ideal for most women. Women who are menopausal, normal range is 0 to 0.1, which I just throw right out the window because that's women they've tested that feel absolutely miserable. Yeah, that's their normal range. Does it feel good? No. So I usually tell women who are menopausal, listen, this isn't like some approved, you know, guideline number, but I find women who are menopausal feel best somewhere like between 2 and 6. They're still not even close to where they probably were when they were cycling. And it's not a target number, but it's like kind of a target range. Most women I work with who are menopausal are like at 2 or 3 or 4 and they feel great. So there are some specific ratios people in conventional medicine use for the estradiol preparations and progesterone of what to use for uterine protection, but I'm not as aware of those specific numbers, but they're out there if you're interested.
Allison, will you be addressing blood levels versus urine versus saliva and what time of day to draw the blood?
That's a really good question too. The question was, am I going to talk about saliva, blood, urine? And I absolutely can, yes. I usually only use serum personally because I'm actually doing a lot of other labs all at once. I think there's value to urine, I think there's value to saliva, but I find that the findings from those are really consistent. If progesterone's low there, it's low on the serum. And because I can do more all at once, I find value in the urine testing for the pathways for estrogen metabolism. So if you have someone who's at high risk for like a history of cancer in the family, again, that doesn't rule them out now, but a lot of people are still worried about it. And just anyone who has any kind of other symptoms that might correlate with a metabolic or detoxification issue, it's nice to know sometimes. I'm not as well versed on like the differences of like the saliva and urine, what might be better for one or the other. But personally, I do default to the serum. Technically, I do fasting labs with people, so technically they're mostly doing it in the morning. But for men to be able to diagnose like hypogonadism, you have to have 2 morning draws 48 hours apart for testosterone, so it matters. But other than that, I don't. Probably there's people who are more well versed with the urine and saliva stuff. It's nice though, because I have people bring in the results from other places, and I see that it's like pretty consistent with the serum. So that's what I use. Sure. Thank you. Oh yeah, that's just, I just talked about it, but that's why it's important to draw progesterone in this phase, because otherwise, you know, you get a bump right at ovulation. I want to point something else too, actually, while I'm here. I've definitely been in the gray area on this one in the past, but it's starting to come out more in research as well, that using testosterone for fertility is actually a really helpful thing. You get a big bump right here. You need to have this bump so that your body will release the egg. So if women are deficient in testosterone and they're not conceiving and they want to be conceiving, that is something to take into account. And there are fertility clinics using this now. Personally, if I have a woman who is really low in testosterone and she wants to conceive, the concern obviously is that if you have too much testosterone, the baby, you could have, you know, androgenize the baby or whatever. I mean, the reality is we have no data to support really. I mean, we don't do a lot of studies on pregnant women anyway, right? But not for this kind of stuff. But all that to say, if you're in a range that's a normal range and you're treating to that range, it doesn't make sense to me biologically why if you're in the range that a normal range would be for a woman for testosterone, if you're there with her because she's deficient, you bring her up to that optimal range, why would that be a problem if she already could be there naturally, right? I do creams, I do topicals so they can stop if they find out that there's a pregnancy. I know that one's probably a little more controversial, but I do feel pretty comfortable with it if people are really low, and I've seen it work. Progesterone is another big one for fertility as well. Okay, so these are some things that come hand in hand with hormone symptoms that I see are not well addressed at all. And again, I want to just mention, like, of course, like diet, lifestyle, stress, we're going to talk about those things too. But the number one thing that I see a lot that is causing symptoms for women that is not well addressed is a low ferritin. So the normal range of ferritin is like, I don't know, I think starts at 20 maybe, but it goes to like 200 for women anyway. If you're below 100, typically you can be symptomatic. So if you're below 100, there's a lot of anemia symptoms that can come up from that. Fatigue, anxiety, you know, just think of any symptom you think of with anemia. Neuropathy, like there's a lot of heart palpitations. There's a lot of kind of confusing symptoms. I didn't used to have ferritin on my intake labs. I do now because pretty much, you know, I don't know, a lot of women I work with, and now I send them over here for veno-fur infusions. A lot of women I work with are like even below like 20 and 30. We try diet, we try supplements, gut healing if their gut's a mess. Some women are so low, same thing. They need that gas in the tank. They are exhausted. They've been feeling like crap. So veno-fur infusions are a great option. Thyroid issues, although I have to say, I see more issues with other things than thyroid, but people come in thinking it's thyroid. But they're really valid in that it's frustrating because they go to conventional medicine, they're like, I feel like crap, and they test their thyroid, they're like, you're fine, but then they're like, bye, and you know, there's like, I still feel like crap. So thyroid can be off and it can mimic those symptoms, but I actually find normally thyroid's okay, it's actually other stuff. Vitamin D levels in New England, I'm sure we all know. I use 50 to 80 as an optimal range. If people are higher or lower and they feel okay and they want to be there, you know, if they're really high, we'll probably have a conversation. But I usually have people on 5,000 I use daily. I do retest. A lot of people have genetic stuff where they might need higher dosing. I have people who take 10,000 daily and they're just at that optimal range. So gut health, obviously, we like have to address that. That's my priority anytime I'm working with anyone. And especially if you're giving hormones, because if you can't excrete them through your bowel movement and you're backing up with estrogen and hormones in your body, that is no bueno. And also the gut health itself could be causing some of the hormone symptoms. Toxic burden, so toxins in our world, they're everywhere. We know they are tied to a lot of health issues. They mimic hormones and they can cause a lot of issues. So a good detox can help with that. Genetic predisposition, I've been getting really into like methylation and gene panels. I've been doing a lot of those. And I find there are some SNPs that are really consistent with especially wonky hormone things that I see a lot. The COMT gene, if anyone's aware of that one. So the MTHFR gene gets a lot of press. I'm glad it is, because honestly, it's becoming more mainstream. And so people are learning about it and it's really helpful lifelong info. I will say I find the COMT gene to be more involved in the really intense like hormone stuff downstream. It has to do with the liver. So if your liver isn't functioning properly, you're moving things out, that's like problematic. And then history of head trauma, concussion, TBI, especially with men. There are a lot of young guys that I work with that have had a history of like, either they played football or boxed or they were in a car accident or something, and they just never felt right hormonally. And when you have head trauma and that very gentle casing of the brain gets rattled around, it's not that difficult to kind of mess up that whole communication system of hormone production. So lifestyle approaches, like, again, I don't want to make it seem like it's in a vacuum. Like hormones, I see do amazing things over and over again. However, it's very rarely just what we're doing. I mean, if I could start with diet and exercise and sleep with everyone, like that would be ideal. That would be great. And a lot of people do start that with me, but again, they're able to do more down the road when they feel better. So diet is such a broad term, but obviously I think, all of us in this room know that, we have to like individualize things. And there are people who benefit from certain dietary things and people who benefit from others, but finding what people's, happy place is for that is going to greatly affect hormone production, use, and excretion. I will say also with exercises, women become perimenopausal and menopausal. One thing I hear a lot is they're often like, well, you used to work for them for body composition, and probably men too, doesn't really work anymore. And sometimes women are used to doing like cardio and starving themselves, and that really did the trick. And now it's like, that's not working. The stress hormone and hormone production that shifts as we go from perimenopause to menopause often benefits. And I see this for men too, and especially with certain genetic patterns, they really benefit from some of those slower, more kind of strength-based or, relaxation-based, but just kind of more gentle movement, or even just kind of, weightlifting versus cardio. So there's a lot there that like you could do multiple talks about. Alcohol intake, that one's always all over the place. Right now, we're in a place where, there's a minimal amount that seems okay, but it really doesn't seem to be a benefit for most people. Whereas we heard for so long, oh, have your red wine, it's all good. It sounds like as we get older, there is more negative impact on our systems with alcohol. And it sounds like as we get to a certain age, more than a couple drinks a week seems to have detrimental impact, but I'm sure more will come up about that. So liver support, gut support, stress hormone support. So this is huge. In my intake, one of the questions I ask people is about their childhood. Do you guys know about the ACEs study? Adverse childhood events. So they did this study, I think it started in the 70s, followed kids for a very long time until they grew up and became adults. So it took a while. So they released the information about the outcomes, and it's turned out that kiddos who had stressful childhood environments had higher levels of high cholesterol, high blood pressure, cancer. There were all kinds of chronic disease. So it's like, okay, this emotional thing causes chronic disease. I mean, all of us in this room probably know, yeah, of course, but like, I know that was, it is a big thing for people to realize. So when I ask people about their childhood, I'm trying to find out, have they had a stress hormone system that's been off very early on? Because we probably need to correct that for them so that cortisol, I showed that slide before, but that cortisol demand, if it's high, it will take the building blocks that you need to make hormones, and it will take it to make cortisol, because that's more important to the body. That's life or death, right? So if you address the stress demand, you're going to have more building blocks to make hormones. So that's another really good way to help hormone production, especially in someone who's younger, who isn't just menopausal or andropausal. Like if they still can produce hormones and stress hormone stuff hasn't been dealt with, they might be in a great place in their life. But if we haven't let that primal brain know, hey, everything's okay now, it might still be running that programming of like, things are not okay. And we need to be able to run at any point, right? So the cortisol's up high. Lots of herb supplements. I actually have a whole slide about it, so I will go into it. But again, that's a very general term, but figuring out what people's specific needs are obviously is ideal. And there's again, like I said, I don't think there's anything wrong with starting with herbals and supplements and see how far you get. You can use symptoms and numbers as a guide. And if that's enough, awesome. Oh, okay. So these are some of the supplements. Oh, and then this one, sorry, I apologize. I'm gonna put a little thing, Indoplex, because I don't think I wrote that one on there. I want to remind myself. So supplements that are particularly well suited for hormone therapy support. DHEA, we talked about the upstream of giving the body the building blocks it needs. So cool, that might just be enough for some people. I have some dosing up there. I mean, I won't get too far into it. If you want me to talk more about that stuff, I will. I will say with DHEA, I often will wait, unless someone's really low. If they're really low, I'll usually bring it on. I usually wait and I'll retest DHEA around 6 months because I'm usually doing a lot of stuff with people in that first 6 months. There are times where people's DHEA levels are better. And so I'm like, if I don't have to give them a supplement, I won't. But DHEA is fat soluble. To me, it can have some side effects that the other supplements I use don't typically have. So if they need it, it works great. I have a lot of people on it, but I'll usually wait to see if it comes around at the corner. Pregnenolone. So so that's like for that reason. So we talked about it, but yes, it's another upstream building block.
Because I've used 100.
For head trauma, so 100 milligrams a night. Okay, so from Dr. Paul Anderson. You know what's funny is I went back in because one of the supplements I use has this in the DHEA, and I had 100 in my head, and I was like, huh, that's weird. It's 25, but that's good to know. Yeah, but for head trauma, yeah, that's really cool. Yeah, that is it's such an emerging thing that we haven't even like scratched the surface of. So if someone has hormone imbalances and they want to take a route or might benefit from a non-hormonal route, Vitex is an herb, or chasteberry is in the name for it. It stimulates progesterone receptors, so it's most like progesterone. So when I'm using it with someone who's cycling, I actually don't use it all month long. I use it just the way I use progesterone, and I don't use it tons, but when I have people using it, I do have them stop after like 3 or 4 months. And then if they need it again, we bring it back on. I'm not an expert in it. I've seen it help a lot. And especially if I'm helping people who are like teenagers or younger people, I really like, if we need to use hormones, I would, but I really find that this kind of stuff works great. And by the way, like so many young women are like suffering with this stuff that just don't get access. I don't use this a lot either, but cohoshes, we've known about those forever. That's all women had forever for menopause, was black and blue cohosh for hot night sweats and hot flashes. I will say that this is a rhubarb, the one on the bottom. So I actually have some people that are perimenopausal, that their estrogen levels aren't super low, but they're having hot flashes, night sweats. A lot of times progesterone and testosterone are enough. So that's great. However, if they're still having some, I have a few people who have really benefited. They're not quite ready for estrogen yet, but that has really helped. So especially like night sweats, hot flashes. And the other one that I did pull out, and I want to say, because I hadn't written this one, it might be in the next one. So this is called Indaplex, but what this is this is a, DIM or, no, it's not estrogen, it's another company. DIM is a component that binds to estrogen and moves it out of the body. So I actually use that a lot for men and women. DIM and endocarbonol 3, although that one just says endocarbonol. So endocarbonol and DIM are products that work well to bind to estrogen and move it out of the body. I'm like, what else do I have on here? Stress support, huge. We already talked about why, but these are my favorites. And I'm not saying it just because you guys are here. They really are my favorites. So when someone has a stress hormone imbalance, I find when you're trying to right the ship, like you're turning a big ship, right? So if we can address daytime stuff and nighttime stuff, that circadian rhythm is what that cortisol response is intertwined with. So if we're rebalancing the circadian rhythm, then we're really helping to kind of turn that ship. So if someone's tired during the day, tired in the morning, crash in the afternoon, wired for sound at night, I rarely do cortisol testing, rarely, because I'll just kind of go on that. And if I address other things, we can use it, and it's a helpful tool if we really need to get in the weeds of like, where might this be most helpful? But I have them use HPA Adapt. It's ashwagandha, maca, rhodiola. I don't remember the other one, but it's a really amazing blend.
What's that?
Holy basil.
Holy basil.
Okay, I was like, there's 4.
4 herbs.
So amazing. Like, I just love it. So it's,
Okay.
yeah, it's a great blend. And then you bring cortisol manager in nighttime, and that's magnolia and ashwagandha. And it's just, I find it really helps get that in line for people. And then, I mean, there's lots of other options, obviously, but those are the 2 I use mostly. Sleep, obviously, like, I mean, we just know the better you sleep, the longer you live, right? So it's like important. There's so many things you can do for sleep. I just will say one of the ones I use a lot, and again, I'm not just saying this because you guys are here, but ProThriver's Wellness Sleep, I love it. It's a really good blend. I will even layer it in. If someone tries Cortisol Manager, it doesn't, it helps, but not great. Personally, I use Cortisol Manager, I use ProThrivers, and I use, I just use like a holy basil also in addition for nighttime, but those 3 work really well, but it works really well for a lot of people. I also just want to say with nervous system stuff, and especially if someone has like a trauma history or a really kind of ingrained cortisol imbalance due to, you know, stressors or traumas, it's really helpful to bring on like somatic or outside modalities for addressing the nervous system. So supplements are helpful, but you really have to get into that kind of primal brain to help it rewire. Of course, he like walked away, but that's my partner, but he does a therapy called Body Talk. They work a lot on the nervous system and wiring. I send a lot of people to him. You can kind of pick who your practitioners are, but having people do work on, and I'll even send people like I don't have time to meditate, and I'll send them literally a link for a 5-minute, you know, a 5-minute meditation. Just wake up in the morning and put it on. So any little bit we can get to move the dial during the day in addition to supplements is going to be huge. Supplements are helpful, but they are not, I don't think they're as impactful deeply in the system as some of these other therapies. I think I talked about those ones. You disappeared while I talked about Body Talk, but just in time. All right. So liver detox support, I totally, you know, we could go into this for a long time too. However, if the liver is not properly moving things out of the system, gallbladder, liver, gut, you're going to get a backup of hormones in the body. That's how they get out of the body, urine and feces, right? So we want to optimize that. Especially there are people with certain genetic predispositions that have higher risk of hormone cancers, men and women, especially with that COMT gene. So if that's there and they have 2 wonky copies, like really, you want to get them on the DIM and IC3. Calcium D-glucarate, I don't use that one as much. I put that on there because that was on a list that Chris and I talked about. I probably should use it more, but I just don't. I know we all have our things, right? But I know a lot of people do, and it's a really good tool. I just can't speak to it as much. Sulforaphane is it's a component that opens up the detox pathways, especially in the liver. It comes from broccoli. This one is huge, especially for a lot of like younger women, like if they have acne, if they have all the like PCOS, there's a lot of liver activity there going on that's like backed up. So sulforaphanes for people who have any kind of like detoxification issue going on can be really helpful. And then gut health, yeah. I mean, I can't say that enough. We need to address that. Okay. I have some case studies. These are some references. Oh, will you go to the next one too? So I wanted to mention a few really good hormone resources if you're interested in getting into this. First things first, Kelly Casperson is absolutely amazing. She's a urologist from Washington State. She's been in the conventional world her whole career. She's still very much in the conventional world. She is like fighting an advocate for women to get access to hormones through the conventional channels. She is petitioning the FDA to take the black box warning off of vaginal estrogen because it is not accurate. And it is preventing a lot of women from getting access to care. However, she talks about like everything. Her podcast is called You Are Not Broken. That's the same name as her book. I have learned so much from her. And you know what is amazing is like she has the research behind it, and she'll talk about whether it's like solid or not. But now as a practitioner has just been doing this being like, well, I hope this is okay. You know, having someone who's got the research behind her, who's studying it, because it's all just emerging. We haven't been doing this research. She is a powerhouse. So I would start there if you're interested for women's health. There's a great podcast episode, especially for men and women's health, but men's health for sure. And they talk a lot about estrogen levels and how guys are so afraid of estrogen getting elevated. But they both, these total nerds, Peter Attia and Andrew Huberman, they've tested their own labs and seen where their numbers felt best. And they both felt like absolute crap when they were in the normal range, 20 to 40. They felt much better when they were like 50 or 60. So I bring that up a lot when guys are like, I'm like, well, how are you feeling? Fine, right? What are you worried about? Men have like a lot of receptors on their heart for estrogen. They have a lot of receptors for testosterone. So again, there's nothing wrong with that. When you provide testosterone therapy, it almost always brings estrogen up with it. For some guys, a little too much, and there's things we can do. But that's one of the first line therapies that I'll bring on, unless it's really high. But I would bring on DIM and IC3 to move that out. Some guys once in a very great while will use a estrogen blocker, but that's really rare. So that's a really good episode that that they did, the Andrew Huberman, Peter Attia. Peter Attia is a huge advocate for hormone therapy. He really calls it out. You know, he's like, this was the biggest blunder in medicine in like the past, 100 years, and the powers that be that caused it are doing nothing to right it. And he's really calling them out. So that's helpful. Okay, yeah, thank you. I already did those. I won't drive those into your brains anymore, but any questions? I do have case studies if we have time and want to, but I would love to take questions.
You get a lot of cases of women with hormonal headaches.
Hormonal headaches. So do I get a lot of cases with hormonal headaches? Yes. for sure.
And what are your favorite?
So the first, I know I'm gonna sound like a broken record. So if someone comes in, if they have any gut symptoms, I'm gonna start there. I mean, it's not that it's the only thing I do, but I'm gonna think, okay, until I address that variable, I can't be sure that that's not like contributing. That can take a long time, right? So gut health is a big one. Progesterone is very frequently, so when women are taking synthetic hormones like birth control, when you test their labs, their blood levels are literally that of menopausal women. So then they get like migraines and stuff, but it's like they're taking hormones, but they're actually suppressing their natural levels, which is why don't get pregnant. We need good options, but like let's get on it so we don't have to use these ones still. So I've actually even used, not very often, but I've used bioidentical progesterone with some of the on-birth control pills before on an IUD.
Yeah, because it's interesting because, you know, they usually give birth control for hormone headaches.
Right.
And I had a patient who would take them forever.
Yeah.
But then during the placebo pills, terrible migraines.
Interesting.
And so she was bleeding towards 50 and I was like, let's just get rid of the birth control and see what happens. No more migraines.
Wow.
But
Yes.
her doctor told her, stay on it because if it's not broken, don't fix it. I'm like, wait, you get horrible migraines.
Totally.
So it took a while to convince her.
Totally. And keep in mind, if she was on the birth control pills, her sex hormone binding globulin was going to be through the roof.
That's what I was thinking.
Right?
She really didn't have much to work with.
Yeah.
She seemed fine when she was.
Yeah, and probably that it's like the when you have, what is it called? Like withdrawal bleeding,
Yes.
right? It's like a withdrawal headache. When the hormones stop, she gets a headache.
Yeah, exactly.
Because it probably like bumped up. One thing I'll say also about birth control pills, and again, I won't go too far into the genetic stuff, but I am like really into it. Birth control pills also completely like deplete your B vitamins.
Yeah.
A lot of people with the genetic issues with hormones are deficient in B vitamins. So then you get them on a birth control pill and it makes it even worse. So anyone I have on oral contraceptive pills, they're on a B complex, a methylated B complex. Yes. And so that if she's like an MTHFR COMT person and she already had that going on. Yeah. Yeah. And you don't, that's the thing, you don't have to. I've only started doing it more because Rupa Health makes that very easy, you know? But before I was just guessing off of symptoms, family history, and homocysteine levels. That was like what I went off of.
Dirty genes.
Dirty Genes, yes. You did? Dirty Genes is a really good book for anyone.
It's really user friendly.
He's amazing. What's his name? Benjamin Lynch. I always want to say Ben Greenfield, which is not him, please, but that's why I asked. So the other genetic thing that I would say with a headache specifically, the COMT gene, big. So the liver detoxification that is compromised with that has so many downstream issues. And you know how I know COMT people also? If I ask people, even if they told me they've done recreational drugs, I'm like, does it take you a lot more than other people? And they're like, oh yeah. And I'm like, okay, let's test your genes, you know?
Kind of high energy people.
Yes. Yeah, really high energy, go, go, go. Yeah, so with the COMT gene, I won't go too far into it, but there's the worrier gene and the warrior gene. And depending on which copy you have, yeah. So there's a lot to be said for the hormonal headache. And then we haven't even talked about probably some other just baseline nutrients. Of course, like we could go there, but those, for hormonally speaking, those are probably like where I'd start.
If they're not on birth control, a little progesterone if they're cycling.
Yes. Yeah, it can. And you're going to know in a couple cycles. Yeah. And then I retest too. So like I want to see, I mean, I rarely, at the doses I do, I don't have people really in high ranges. I retest just, I have certain timeframes intervals that I test in, but it's rare that I see them.
What is your favorite dose for progesterone?
For women who are still, oh yeah, sorry. What's the dose I'll start with? So I'll give you the dose for menopausal women and cycling women. When I have women who come in who are cycling and they're low in progesterone, I'll start at 200 milligrams, no problem. That's day 14 through the start of their cycle. Many of them go up to, oral progesterone. So one thing I should say right now, thank you for reminding me, transdermal it does not get absorbed well at all. Could you try it? Sure, you can test numbers and symptoms, but first of all, progesterone really helps with sleep, so you give it at night. So if women are using progesterone during the day in a cream, it's probably not doing much, and you're not getting the benefits of sleep. Secondly, if you're using it in menopause, it's not good because you're trying to keep the estrogen effects in check with the progesterone. It's not absorbed well. So it needs to be a capsule or oral troche, rapid dissolve, like you can do any of those. The capsule, I'll normally start at 200. I have many women who are cycling at 250. I have one woman who really wants to be at 300. Her numbers look fine. That's as high as I've gone, honestly. My case study, though, I had a woman walk through the door who was like hemorrhaging for the past 40 days, and her PCP was like, oh, well, your annual's in a couple months, like just hemorrhage away. I've never done this, but I actually started her before I even had labs. I'm like, whatever, they do this in conventional medicine all the time. I did a progesterone taper with her. So if anyone's been in conventional medicine, one of the things they use when women come in with heavy bleeding is something called a agestin taper. It's a really high dose synthetic progesterone. So I was like, well, let's just try it and compound it. So I actually started her 600 milligrams for 3 days, 400 milligrams. And if we get to the case study, you'll see her bleeding stopped immediately. She got back to regular cycles within like a couple months. You should know if progesterone's working in a couple months. It's really, it shouldn't take that long. Menopausal women, I might start at 100, 150. Many of them are at 150, 200, not a problem. But again, I find if the ratio is supposed to be lower, I don't need to start at a higher dose. If a woman's perimenopausal, you're kind of walking that line, but I'll usually start at 200.
You have a question.
Sure.
That's coming from Waltham.
Waltham.
Dr. Conrad.
They're
gonna unmute.
All right.
Microphone.
Yeah, that microphone's so cool. I feel like we're in like a video show.
So, I would like to take your pick on. So you have 75 years old woman who comes to you. She is not quite sure whether she needs hormones. You know that she has a slight coronary artery disease by coronary calcium score, not symptomatic. Let's say coronary calcium score would be like 500, so not that small. And then you know that she has like 10 years ago thromboembolism, which, it could be provoked by oral contraceptives or some others, not sure. Then she wants to have better brain, of course, at 75, and she wants to have maybe better bones, but the bones are not that bad. She has like osteopenia. So how your counseling would look like, I wonder. What would you tell her? And she's not quite sure whether she wants to. She would like to pick up.
All right. Can I ask you one thing before you go? When you said she's not symptomatic, do you mean the cardiovascular symptoms aren't present, or do you mean
no symptoms whatsoever? She's, she just wants to be well and live, good life. No symptoms, no cardiovascular symptoms, just coronary calcium score elevated, quite elevated, 500 or this kind of range. Thromboembolism in the past, that was like long, 10 years ago, 15 years ago, something like this, distant past. Family history, strong family history of coronary artery disease, family history of thromboembolism, but she would like to have better brain and better bones and, maybe improve sleep. So what would you tell her?
Yeah, that is such a great question. I feel like you've described people who have walked through the door before. So it's a great question. What I would want to do is first find out what are the symptoms that are most prevalent for her and what are her goals. So if she has vaginal dryness, urinary symptoms, but nothing else, well, great. We don't even have to worry because we can put her on vaginal estrogen without a care in the world, really, because that's not going to translate into elevated serum estrogen levels. So that right there, if that does it for her, great. However, it's not going to treat osteoporosis. It's probably not going to have the brain health effects that we know are there. I live on the edge a little more. So I'm just going to come out and say that to everybody. I do live on the edge a little more, but I feel pretty comfortable there because I retest labs so much that I am working with women who I can see where they started with their estradiol level. And what I would say is, if the symptoms are like her hormone symptoms don't sound strong enough that they're like getting in the way from day-to-day living. So I would say to her, if she's not osteoporotic and she doesn't have any kind of current, brain health symptoms, I don't know that I would put her on topical estrogen if she doesn't need it. If she's not sure, if she has, if she has actual osteoporosis or osteopenia, I think it's an option on the table. However, I might say, hey, let's talk with your cardiologist about it. Let's have a conversation. So with the thromboembolism, one thing I'd want to know is if she's, has she been on birth control pills before? Has she been pregnant before? Because if she has, we've raised that estrogen level. We've kind of tested her body. Was the thromboembolism from one of those things? I'd want to know, because if she had a reaction to estrogen, again, transdermal, it shouldn't be a problem, but I'd probably be starting a lot lower. I've worked with women who are in their 70s who have come in to see me, who have been on hormone therapy years ago and want to get started, I feel a little more comfortable with that. I've also worked with women who have never been on hormone therapy and are in their 70s and want to, and I just start very, very low and go very slow. And I talk to them about how we don't actually really know. We don't have great data, but from what we know now, the cardiovascular risk with transdermal estrogen is very low to none. But I don't know that that's worth putting someone on hormones who doesn't really need them. Do you know what I mean? So I would really ask her, what are her goals? What are her top symptoms she wants to deal with? If she tries the vaginal estrogen and things are good, then that's great. So I would have a conversation about, you know, what is the risk benefit and what is the value to her? But if the symptoms are strong enough, if someone really is pretty symptomatic, then I will start at a really, really low dose. So what I typically compound for estrogen is 5 milligrams per gram. And I'll start most women on a click in the morning, a click in the afternoon, which is basically a half gram. So it's like 2.5 milligrams. If I were working with that woman, I'd probably start compounding the estrogen at 2.5 milligrams per gram. And I'd probably start with just 1 click a day. It probably won't even honestly move the dial on her labs, but it might help with some of the kind of prevention. You know, when you're looking, it's hard to compare pound for pound because when you're talking about commercial preparations, they're just, you know, when you're talking about a patch, you can't compare it. But that's that. I wouldn't rule it out. And I would have a conversation with her to say, I don't have much good data, but we do have enough good data to say the transdermal should not be causing any thromboembolism.
And if the goal is brain health, mainly for this patient, you have other tools in your toolbox.
Exactly. Thank you. Yeah. For brain health, I also would definitely be talking about a lot of other things. Another supplement I love that I use a lot of is the neurologics that Integrative makes. So it's saffron, peppermint, cognizant, that's a big one, and spearmint. Love that one. And I have a lot of people on that. So yes, thank you. Brain health, if that's the goal, there are a lot of other tools to bring on. And we don't really have great data yet with hormones and brain health, even though a lot of us are like, yeah, I see a woman who can't even remember the name of her firstborn child and she gets on estrogen and the next day she's like remembers everything, right? Like we see that. Oprah, you know, once Oprah starts talking hormones, you know things are going to change. But Oprah, the first thing she felt when she started hormones was her brain fog cleared and she was like, wow, why did I live that way, you know? Other questions? I don't know what time it is. Sorry. I could blabber all night long. Okay. I do. Yes, I use. The question was, do I use vitamin K2? I do. The vitamin D I prescribe for people who suggest. Oh, for brain health and coronary artery disease, K2 as a suggestion for addressing those things. Thank you. Yeah, so, and thank you to the point of if we are going to bring hormones on, also doing things to address the cardiovascular and coronary artery disease is obviously also helpful. I would also argue just a good B complex, because if you have someone with an MTHFR gene variant and they have a cardiovascular risk in the family, you could do a methylation test. You could see where are their methylation markers, and we know that that correlates with cardiovascular risk. So you could even get upstream there and figure out where are the SNPs that they have that are affecting that. What is it?
Magnesium.
Mag 3 and 8. I know this is all the ones we have at our office and we take them and then we're like running around the office. Yeah, we do Mag 3 and 8. We do neurologics. Yeah.
Some more questions. What is your approach with women who are hesitant to go on HRT, specifically estrogen, due to family or personal reasons?
This is such a good question, and kind of with the last person who asked a question too. I want to say this. I don't ever talk anyone into anything. If someone comes into me, and most people I work with are like, I want hormones, so they know. Many people I work with are already kind of there and have educated themselves. If a woman comes into me and has a family history, I'm going to talk with her about the new data that says that does not rule you out as a candidate. And in fact, women who are on hormone therapy have better outcomes for breast cancer. So that right there, I would clarify. But if she's not sure, I'm like, let's do other things. I actually very rarely will jump into hormone therapy. Even if I can see on her labs, I do a lab review and I teach people what symptoms are correlated with what numbers probably. And they usually make decisions to do that. But I don't ever, like, I'm basically like, here's all your menu options. What does your intuition tell you? And then they choose off that menu option. And if someone isn't sure about hormones, I tell them, let's wait until you are sure. So I actually wouldn't probably push them over. If they were osteopenic, if they had frequent UTIs and they were older, if there were other things that were really strong benefits of hormone therapy that have been completely like represented, I would probably have more of a conversation so they know, but I never ever am kind of pushing it.
We're good on questions.
Okay. All right. Yeah, I'm happy to send, I brought labs and stuff, so people I know who want to get more in the weeds, I'm happy to send stuff and do that, but I really appreciate everybody coming. That was awesome. Thanks everyone out there.
They were curious if you can share the
Thank
slide.
you.
Yeah. Hi. I'm happy to share the slides. I'll send them. There's actually a lot of like labs and case study stuff. So if anyone even is like interested, I mean, I'd host a group and kind of go over it if you want, because I am a nerd like that. And I would love to like do that stuff if people are interested. So I'm happy to share them. And just know, let me put a qualifier. These are all my numbers that I use. They are not like recommended guidelines. So just know that.
Awesome. Thank you.
Thank you.
Yay,
Thank you. Thank you for
Thank
all
you,
your
Allison. Appreciate it.
changing.
Yeah.
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 Also
Yes. Okay, very good. So, you know, it looks like, yeah, it looks like.
Yeah.
Yeah.
Yeah.